talking on slow swell phaco. And the discussant will be Dr. Virendra Agarwal.
Good afternoon, everybody. I'll be presenting my video.
Slow swirl phaco.
Slow swirl phaco is a novel surgical technique for soft posterior polar cataracts. This technique does not require hydroprocedure or rotation of nucleus. There is no sculpting, cracking, or chopping of nucleus. Machine parameters are kept low. Following capsular rhexis, the phaco probe is inserted and moved in a swirling fashion. The movement is from center to periphery and also from superficial to deeper layers. The aim of the swirling movement is to remove the central chunk of cataract. So, a large crater is created with the exposure of the underlying polar opacity. Some amount of spontaneous hydro from the irrigation sleeves help in removing the cataract in layers. The epinuclear layers opposite to the incision can be aspirated then with the phaco probe in low parameter settings.
The subincisional layers are also shaved off by swirling motion of the phaco probe. Once a slow swirl is complete, what is left behind is the central polar opacity and the subincisional thin epinuclear plate. Visco is then injected and the phaco probe is withdrawn. Now, controlled viscodissection is then performed in multiple quadrants in order to loosen up the subincisional epinuclear sheath. This can be then removed easily using the coaxial probe. The polar opacity is removed last. Not all cases of slow swirl technique requires viscodissection, as in this case. Here, slow swirl technique is performed. What is left behind is the central polar opacity and the subincisional epinuclear sheath. Instead of performing viscodissection, here a blunt-tipped spatula is inserted from the side pole and it is moved in a swiping fashion in order to loosen up the subincisional epinuclear sheath. It is then aspirated easily. In cases of slow swirl phaco where there was a posterior polar plaque, posterior capsular rhexis was performed. This was a young patient who had a dense posterior polar plaque and pre-existing dot-like anterior vitreous opacities. He underwent a slow swirl technique and he had no breach in the posterior capsule iatrogenic. It has been employed in 20 patients with soft posterior polar cataracts and none of the patients had any iatrogenic complications. The advantages of this technique are that it avoids hydro procedures which could predispose to posterior capsular rent. Viscodissection is avoided or minimal. It avoids fluctuations in the anterior chamber and the polar opacity is removed last. Hence, it's a safe technique. Thank you.
Thank you. I must appreciate the effort you have done. But what was the size of rhexis?
So 5mm rhexis.
Because I think to remove more of the material, you'll require to have bigger rhexis, which we usually prefer not to be big in posterior polar cataracts.
Yes,
because sometimes if it is required, we
if there
can
is a
use
rent, we need to use it.
yeah, optic capture something. So
we could do a oval rhexis also, sir. So it will be a little easier to do epinuclear removal, I think.
Yeah, so the one thing that modification may be required. The another thing, using this technique in very soft, sometime will cause that the whole of the lens material
Yes, sir. Yes,
will expose the posterior capsule.
Yes,
So I think doing mild hydrodelineation will be more useful than this.
Yes,
That is another thing. And the third thing is that you are using a tip which is almost 30-degree kind of thing.
Yes, sir.
So you can use a 0 degree or 15-degree tip. That will be better for these kind of short swivel movement.
Okay.
And preferably it should be done through 1.8 millimeter phaco kind of tip, so you have easy maneuverability rather than a normal 2.2 or 2.8 phaco. So
Okay,
these are
sir.
my suggestions, but otherwise it's a good approach.
Thank you, sir.
Thank you.
Thank you. Thank you.
Call the next speaker.
Yeah, now I call upon Dr. Apurva for her presentation on innovative bladeless pterygium surgery, a non-traumatic approach. The discussants would be Dr. Nandakishore and Dr. Arun Kshetrapal.
You can't sleep.
Party there.
Can I start?
Yes, yes.
Good afternoon, everyone. My name is Apurva, and today I'll be talking upon bladeless innovative pterygium surgeries, a non-traumatic approach. As we all know, that pterygium is a progressive, non-inflammatory, and wing-shaped degeneration of the conjunctiva over the cornea. Because it is an agricultural country in India, UV rays have raised the risk of pterygium to a higher level. And but pterygium excision surgery can be performed by any ophthalmologist, may it be a retina surgeon, a glaucoma surgeon, cornea surgeon, or a cataract surgeon. So the need to know about the pterygium excision surgery is very important for all the surgeons. The pterygial excision techniques available are bare sclera technique, amniotic membrane grafting, CAG with sutures, and CAG with fibrin glue. But for pterygial head removal, we mostly use blades, that is beaver knife, 26 gauge needle, scalpel blade, diamond knife, and crescent blade. If you are a senior surgeon, then you will know how to get the correct plane of dissection and how to dissect the tissue from the corneal tissue. But if for the novice surgeon, it may lead to complications like reduced wetting, retained tissue, injury to the Bowman's membrane, irregular plane of dissection, or poor cosmesis. To avoid these complications is new surgeons, which are learning pterygium surgery. We have come up with two innovative atraumatic techniques, that is the Terry snip and Terry peel.
Terry snip, a suture-based pterygium removal. Step
So-
1. A superficial epithelial incision is made with a 26-gauge needle parallel to the head of the pterygium. Step 2. A small nick is made in the lateral borders of the neck of the pterygium. Step 3. A cyclodialysis spatula is passed beneath the pterygial tissue from one end of the neck to the other to create a clear dissection plane. Step 4. A 4-0 silk suture is now passed in the same dissected plane. Step 5. Tight hold of the suture ends is obtained by using a clamp and tying forceps. Step 6. A slight countertraction is applied toward the base of the pterygium, with the spatula that's held in position under the neck tissue by assisting step. Step 7. Swiping movements are then made along the dissection plane toward the apex of the pterygium. This action will remove the entire pterygial head with no residual tissues underneath.
So the disadvantages of this technique are 2 people are required for the countertraction, and the abnormal plane of dissection can lead to retained tissue post-surgery.
Bladeless technique
In the
is
second
ptery
technique-
peel, a peel-off technique for pterygium head removal. Step 1. A superficial epithelial incision is made with a 26-gauge needle parallel to the head of the pterygium. Step 2. Identical to a conventional pterygial head removal, the neck of the pterygium is cut with scissors at the limbal border. Step 3. A good grip of the complete pterygial head is obtained with a clamp. This clamp helps to achieve hemostasis in the bleeding pterygial tissue and also aids in easy removal. Step 4. The clamp is then used to peel off the pterygial head in a centripetal pattern so that the entire head is removed in 2 or 3 movements. The residual tissue after this technique is so minimal that it completely alleviates usage of the blade, and a simple polish with a burr is adequate.
So the disadvantages of this technique are customized instrument for grasping is not available, and lack of counter traction can lead to globe traction, and harder grades of pterygium are difficult to manage.
These are our 2 simple and effective techniques for a bladeless pterygium excision that anyone can easily adopt.
Yeah, I noticed that you still used a blade in the
Sorry?
second procedure.
Yes, sir.
And then instead of a blade, you used a 26 gauge needle. What's the specific advantage? I mean, it's some form of cutting, whether you use a blade or a needle.
Sir,
Does the needle help you in any particular way to control your depth of cutting,
sir,
or it's the same with the blade?
So in needle, we are only doing a incision over the superficial epithelium. We are not going any deeper. So just for the plane, so that it doesn't go any further, that we are removing the tissue. We are just cutting it to give a border of the cut to come out. We are not going to cause the. We are not trying to dissect the plane with the needle, sir. The plane we are trying to get from the base of the pterygium so that we can extend that same plane, because new surgeons, we are finding it difficult to find the plane. They keep on scratching with the blade, and then it leads to multiple planes, and retained tissue is left at the end of the surgery.
Even in the peel technique, I noticed that there was some residual tissue left.
Yes, sir. Little bit, if even if little bit residual tissue is there, so it can be loosened, and it can be washed off with the little minimal burr usage, sir.
Excellent technique. The idea, I think, behind giving a cut is that you don't peel more of an epithelium. So epithelium peeling is limited to that area. Excellent idea. I think this technique will work with atrophic pterygiums and will not work in the young people who have very strong adhesions. I'm slightly skeptical whether this will work in
Yes, sir.
young.
So mostly it is for the getting the correct plane of dissection, and then it is not for the severe grades of pterygium. Mostly for mild to moderate grades of pterygium, which
Yeah,
is
and maybe atrophic pterygium in the older
Yes.
people. It will work fantastically well,
terrific.
I'm sure.
Yes, sir.
Thank you very
Thank
much.
you.
Thank you.
Thank you.
Yeah. Next we have Dr. Nadella Vishnuvardhan, who's speaking on fiber or plaque.
No. No. He's the discussant.
Okay, sorry.
No,
Yeah,
sorry.
sorry.
Huh.
Yeah, Dr. Ravi Kulkarni, and the discussant is Dr. Nadella Vishnuvardhan and Dr. Chandrasekhar Varikar.
You'll have had your lunch, no?
Good afternoon, everybody. It's playing. Sound.
Dr. Chandrasekhar's name was
Sound volume.
Time, reset the time.
Volume is not there.
The audio should be connected.
Exactly does that.
One.
After aspiration of complete its safe removal of the last bit of fibers from the capsular bag is very crucial in every case to achieve a clean bag. Here is a technique which exactly does that. After aspiration of the nucleus, a jet of BSS is injected from the main tunnel, hitting the posterior capsule tangentially, loosening the fiber or plaque from the posterior capsule. 24 gauge cannula mounted on a 2 ml syringe. The piston is taken out. Now only outer jacket is available, and 24 gauge cannula is ready to take out every bit of fiber plaque from the PC. AC maintenance is on, and bottle is at around 100 centimeter height. 24 gauge cannula is taken nearer the raised edge of the fiber or plaque. The BSS gushing into the syringe through this 24 gauge cannula passively will take away all the fibers safely without damaging the posterior capsule. Let us see another case. A jet of BSS is hit gently tangentially to the posterior capsule to loosen the cortical fibers. 24 gauge cannula mounted on a 2 ml syringe without piston. The globe is stabilized with one hand. The 24 gauge cannula is taken nearer the raised edge of the fibers. BSS flowing into the cannula will take away all the fibers safely. At times, you can see here posterior capsule comes out to the port but hardly gets damaged. Hands are changed. Fiber cleaning is done from the opposite side. One should have a lot of patience so that the fiber removal is done safely and completely. The trick here is opening of these cannulas is at the tip. Area available is more compared to the ports of a bimanual where the opening is at the top. This is another case. The jet of BSS will loosen the PC block. The eye is stabilized with one hand. The 24 gauge cannula mounted on a preview syringe without piston is taken nearer the raised edge of the block. The BSS gushing into the syringe through this cannula will take away all the fibers safely and completely. There is no active aspiration here. The BSS flows passively, taking away all the fibers. To conclude, this is an innovative technique where these tiny instruments are used to help out complete removal of the last bit of fiber or cortex, which is very safe and highly reproducible. Thank you very much.
Thank you. Nicely done.
It's a nice presentation. What is the advantage over CAPAC technique?
What's it?
What is the advantage of this procedure over the CAPAC procedure? CAPAC can
CAPAC
have
you
more
can
control.
do, but you'll be aspirating actively. At times PC may come. If it is very much adherent to the PC, it may come. Here I have done in many cases, none of the time it has, I have damaged the PC. I found it very safe and very easy, very simple.
You can control all parameters in CAPAC also. But of course, it's definitely a new approach, innovative method.
And the port is at the tip. The area available is more. All of the things you can peel it off.
That's good.
Thank you.
Yeah, excellent. Only two questions. Did you have to hydrate the side ports so that the entire flow is directed towards your syringe?
No need, sir. The opening is very small. 24, 23 cannula only can go. Snugly fits in. No
Yeah,
need.
but suppose there is a leak from the side port, it will decrease the efficiency of your system.
No. Because AC maintainer maintains it all throughout with the same pressure. When it is more, when the fluid is coming more, AC maintainer will, flow will be more.
And did you try to adjust bottle height to change the, the flow? Sometimes, decreasing the bottle height may make it more gentle.
No decreasing, sir. It should be above 100 only. If you have done already 3-4 cases, the liquid is less, BSS is less, I may increase it to 110, something like that.
Suppose the patient has advanced glaucoma or very advanced diabetic retinopathy, we are bothered about the intraocular pressure.
Yes, of course, it affects, but hardly it takes 15 to 20 seconds.
Excellent. Thank you.
Thank you, madam.
Thank you, doctor. You can collect your certificate. The next presenter is Dr. Ashish. He'll be presenting on a hybrid 26 gauge needle drainage technique in scleral buckling, and the discussant will be Dr. C.V. Gopal Raju, sir.
Very good afternoon to all. So I'll be talking about hybrid 26 gauge needle drainage technique in scleral buckling, a mini scleral cut down. So there are various techniques to drain the fluid from drain subretinal fluid in cases of scleral buckling. And the initial technique was described by Shippens, which was actually a two-step scleral cut down, where he used a scleral blade and then diathermizing the choroid and then using a needle to drain the fluid. Because of the large sclerotomy, there is a risk of retinal and vitreous incarceration, bleeding from the choroid, and sudden hypotony. To counter this, there are various other needle drainage techniques which have been described, like needle drainage technique, modified needle drainage technique, and a guarded needle drainage technique. Now, the technique described by Charles et al., it involves the use of indirect ophthalmoscopy and a use of a 25G needle, which passes obliquely through the sclera into the subretinal space. The problem is that it is a steep learning curve, and also oblique passes through the choroid increases the chances of choroidal hemorrhage. Contrary to this, the technique described by Azad et al. Uses a 26 gauge needle without a plunger, does not require an indirect ophthalmoscope, and it causes, and we have to go perpendicular into the subretinal space. But the problem which I felt while I was in my residency doing this modified needle drainage technique was that as soon as the needle enters into the subretinal space and crosses the sclera as well as the choroid, there is a sudden loss of resistance. And as a result, the needle just gives away, and there's a high chance that the needle might go and hit the retinal surface, especially in cases of shallow retinal detachments. So there's a jerk which is felt as soon as the needle pierces the choroid as well as the sclera. So basically, to avoid this jerk, we have described a technique where we perform a mini scleral cut down using a 26 gauge needle, and we have called it as a hybrid needle drainage technique, which is a hybrid of a scleral cut down technique and a modified needle drainage technique. So in this technique, basically, what we do is we create a mini scleral cut down using the tip of a 26 gauge needle. So here, this is done by doing linear movements and scraping of the scleral surface. And this is done till the choroid starts to appear. So it is at this point that very gently you poke inside the subretinal space using the tip of the needle. And it leads to a passive aggression of fluid. Following this, a cotton bud applicator is used to basically drain out rest of the fluid. So we've already published this technique as a pilot study in Indian Journal of Ophthalmology, and it was a retrospective study where we evaluated the efficacy and safety of hybrid 26 gauge needle drainage technique in scleral buckling. Intraoperative surgical details and postoperative details were noted down, and the adequacy of drainage was assessed by indirect ophthalmoscopy. And it was graded from grade 1 to grade 4, where grade 1 was defined as a complete drainage of subretinal fluid, whereas grade 4 was defined as dry tab. So a total of 10 patients were done, and a complete drainage of SRF was achieved in 5 patients, and a partial but adequate drainage was achieved in rest of the 5 patients. In none of the patients, inadequate or dry trap was encountered. No intraoperative complications were encountered. And in most of the cases, we were able to drain in a single attempt. Only in 2 cases, 2 attempts were required. The retina was attached in 8 out of 10 eyes at 1 week and 1 month of follow-up. So till date, we performed roughly around 70 to 80 cases with a similar technique. And what we have found is that it has various advantages, like it is more controlled, and this can even be performed in cases of shallow retinal detachments. As the point of entry through the choroid is so small, diathermy of the choroid before entering into the subretinal space is not required. This small opening in the choroid also avoids the risk of vitreous or retinal incarceration. And as the needle is entering into the subretinal space in a perpendicular fashion, so the chances of choroidal hemorrhage or subretinal hemorrhage are drastically reduced. Thank you.
Yeah, that was a good innovation, but only you are using the needle instead of the blade of the earlier technique, and then the size also it is less when compared with the.
Yes, sir. The problem with needle technique is, sir, it gives a sudden jerk most of the times. So it is always better to scrape off the scleral surface first. It will reduce the resistance, and then one can easily poke in.
But earlier we were using the blade and then cauterizing.
Yes,
so
sir.
this is only you are avoiding cautery, and then the opening also is less. These are the 2 improvements.
Yes, sir. But with the blade, there is no we are not able to actually scrape off the scleral surface. We can actually make a cut in the sclera. In this, even if it is a thin sclera like high myopics, you can actually control how much amount of sclera you want to scrape off. And then as soon as the choroid is visible, you just gently poke inside.
Okay, good.
Thank you.
Please collect your certificate. Dr. Gopal.
The next presenter is Dr. Mudit. He'll be presenting on a new technique for rheumatogenic RD, and the discussant will be Dr. Jignesh.
All right, so first of all, good afternoon and thanks to ARC for giving us a chance to present our work on using fibrin glue in retinal detachments. Now, we all know that whenever we do a pars plana vitrectomy, vitrectomy for detachment is now becoming more and more common. In fact, in one of the practice and trend surveys, we found more than 70% of surgeons prefer a vitrectomy in cases of inferior RDs also with a single tear. Now, the problem is that whenever you do a vitrectomy, we end up using silicone oil or gas tamponade in all of these cases, and they come with their own set of problems. You need to give a post-operative positioning to all of your patients for at least 2 weeks. There is always a risk of glaucoma, corneal changes and cataract. There is a delayed visual recovery till the time you do a second surgery to either remove oil or till the time your gas bubble gets absorbed. You need to do a repeat surgery to remove the oil. And if you have put gas inside that, then there's a restriction in air travel. And therefore, we decided to see if we can obviate the problems that silicone oil or gas produces by using fibrin glue as a tamponade. Now, what does a tamponade mean? Tamponade essentially are agents which provide surface tension across breaks in order to prevent fluid from flowing back into the retina till the effect of the laser becomes permanent. and it takes 48 to 72 hours for the laser effect to come. So you essentially need a tamponade agent only for 48 to 72 hours over here. And fibrin glue, the agent that we thought of using, has already been used extensively in ophthalmology in ocular surface procedures, in scleral fixation of intraocular lenses, but also in retina, in optic disc pit associated detachments, and even in macular holes. Fortunately, we also have animal studies which show that it is not toxic to the RP. So we have an agent which has been used in retina and is not toxic to the retina at all. And therefore, we decided to explore its role in detachments. So the technique is pretty simple in the terms of whatever you were doing earlier. Do a vitrectomy, settle the retina, do a laser. But now after doing a laser, instead of putting oil or gas, you put a drop of fibrin glue to cover the break. No post-operative positioning needs to be given to any of our patients. So this is one of our patients, and here if you can see over here, we did a surgery for this patient. The initial steps are simple. You do a complete vitrectomy, remove all of the vitreous. Subsequently, after removing the vitreous, you do a fluid air exchange through your retinotomy. After you have done a fluid air exchange, you do a laser. But after doing a laser, that's when the next step comes. Now in an air-filled globe, over here, after completing of laser, you put 1 drop of fibrin over the break. And after waiting for 2 minutes, a coagulum gets formed. Now this coagulum can be just easily lifted. And after you lift it, you can just place it to cover the break. And that's the end of the surgery. You don't need to put oil, you don't need to put gas. And this is how the patient is the next post-operative day with the retina attached, visual acuity improving to 20/100. At 1 week, the entire fibrin glue goes away, it gets absorbed spontaneously, and you have an attached retina, and the patient did not have to sleep in a prone position. You don't have to put oil, you don't have to put gas. This is one more of a patient with an RD. This is how the patient is on the first post-operative day with absolutely clear media and fluid inside the and an attached retina, and the coagulum goes away in 2 weeks. So we have now done it in more than 50 cases, and our outcome measures were anatomical attachment and improvement in visual acuity. And at just 1 week, see, the entire visual acuity improves to 20/80. This is something which we could never ever achieve with conventional tamponades. So these are some of our cases. Inferior detachment, this is how the patient is at 1 week over here. Another patient with vasculitis and detachment, and this is how again the patient is now at 2 weeks. Another patient with an inferior RD 2200 vision, first post-op day at 1 week and at 2 weeks. We have now even started exploring it in some of our TRD cases. So this was a patient of SLE with a break over here inferiorly. And this is how the patient on the first post-operative day, under fluid eye, attached retina, coagulum covering the break. 1 week, the coagulum gets absorbed, leaving behind an attached retina. So fibrin glue now allows us basically an opportunity of an absolute early post-operative recovery in an RD patient, visual acuity improving within 1 week, no positioning, no gas or oil tamponade. Thank you so much.
Fantastic. It's going to be a game changer because you're going to stop using silicone oil and all the complications which are coming up will be stopped. So it's very nice. Only what is the follow-up period for such cases that you have, and what is the vision? Is it stable or is going down or is coming better?
So we started doing this surgery for the first time in 2019-20. We now have patients who have a follow-up of more than 2.5 to 3 years also, and their visual acuity is stable and maintained. So the visual acuity that comes at 1 month finally gets maintained and stays that way.
And what is the site where you have put the fibrin glue? What is the status there? Does it go into fibrosis or
nothing at all,
is there any pucker which is appearing because of the glue, because of the contraction?
So
anything that you have noticed?
Pucker at all, because this is a protein. It gets absorbed spontaneously by itself within a span of 8 to 10 days. So there is no pucker that has occurred over there. We have been able to do serial OCTs over that area, and all that shows is a flat retinotomy with surrounding laser marks, but no membrane, no pucker. In fact, theoretically, it will actually even reduce the chances of PVR, because how does PVR occur? It occurs because of RP which gets proliferated. Now you have covered the break, you are even preventing RP from coming out. So theoretically, you are even reducing the chances of PVR occurrence in these cases.
Fantastic innovation. Thank you very much.
Thank you. Yes. So the size does matter. Thank you so much for that question. So this is a technique which is used for early simple RDs with breaks limited to 1 or 2 quadrants. For extremely large breaks, which is breaks larger than 3 disc diameters, we do not recommend it. And the reason is that if you put it in a very large break of more than 3 diameters, the problem is that this glue can go subretinally and it will not then serve the purpose.
What about the clock cars? Have you covered 360 degrees all the one thing, only in the dependent and superior position? Which positions have you got the maximum
results? So we have done it for inferior RDs, we have done it for superior RDs. We have now done it in total for 57 cases. Of them, 29 were inferior retinal detachment. It works extremely well in inferior RDs, also in superior temporal nasal. Once you have put a drop of fibrin and the coagulum is formed after 3 minutes, it doesn't go away anywhere. It stays that way.
Fine. Thank you, sir.
Thank you so much.
We go on to our next.
The next speaker is Dr. Sunita, and she'll be talking on the modified technique for treatment of large acute hydrops. And Dr. Swapna Nair will be the discussant.
Hello everyone, so I'll be talking on a modified technique of management of acute hydrops. Acute hydrops occurs due to sudden split in Descemet's membrane and the Duas layer, and there are several ways of managing. This doesn't go forward. This doesn't go forward. Okay, so
Can someone reset the timer? Reset the timer.
So there are several methods of managing hydrops, and there are several problems with each one of them. And in view of this modified technique of compression sutures was decided upon. I'll be discussing 3 situations where this modified technique of compression sutures was applied in the setting of keratoconus, pellucid marginal degeneration, and a hydrop secondary to trauma. This is the first case of a keratoconus which was non-resolving for 3 weeks. And the technique involves making a side port. A small air bubble, 100% air, is utilized into the anterior chamber to define the plane at which the posterior membrane is. These sutures are partial thickness and not full thickness compared to the previous technique described. And the reason for this is that when there's acute hydrops, there's a significant large edema, and it is hard to delineate where the Descemet's membrane is. So one need not go very deep, and we can remove the air at the end, and we can see the remarkable resolution of edema happening right intraoperatively itself. These sutures can be subsequently relieved. And this is the post-op day 1, where there's a remarkable improvement on the day 1, and post-op day 3, showing remarkable resolution again in this particular case. This technique can also be applied for pellucid marginal degeneration, where there's a peripheral edema, and this is one such case where the same technique was applied with compression sutures. In pellucid, the break is centric to the limbus, and hence radial sutures are applied. So this is the pre-op and post-op on the same day. So this was the case of post-trauma with a thin cornea, and we can see there's a Descemet's membrane, posterior membrane split 360 degrees all throughout, and this is the cause for the large hydrops. Same technique applied, the side port is made, air bubble is injected to define the plane of the level of suturing, and partial thickness sutures are again taken. And in this particular case, since the breach is circumferential all throughout, sutures have been taken circumferentially all throughout, just like we do for a PK, because the split was all throughout 360 degrees circumference, followed by which a BCL and the contact lens is applied after removing, and very trace amount of air bubble is used. There's no C3F8, there is no SF6, and no tamponading gases are used. Now, this is the post-op day 1. The patient has a remarkable recovery, and post-op 1 week when the patient's vision acuity was restored. So compared to the conventional things, what are the modified steps? We take partial thickness sutures. This makes suturing way easier in grossly edematous hydrops. Sutures act as draining the fluid like venting incisions, and resolution of edema is pretty much rapid. 100% air bubble is used instead of C3F8 and SF6, so it eliminates the risk of pupillary block and C3F8 and SF6 gas bubble related complications such as pupillary block and Uritz-Zevalia syndrome and cataract formation. This technique is non-dependent on gas and air in the anterior chamber, and hence it is effective for inferior breaks as well, and can be applied to diverse indications we saw in keratoconus, pellucid, and trauma-related. What is the suturing strategy? The guiding principle is based upon perpendicular to the tear when it can be identified. These are the cartoons showing the various techniques in which the suturing pattern is taken. If we can't identify the break, one has to take arc weight, and we can use various patterns of incisions, sutures, which could be infinity sutures, figure of 8, and mattress sutures. In pellucid, it is more radial. Identifying the posterior tear can be done by using the endoilluminator, and the mechanism of quick resolution is based upon the concept which is analogous to external tamponade in buccal surgery for RD. So this brings, the compression sutures brings the biomechanically weak cornea closer to the posterior defect, thereby facilitating the natural process of resolution. So an outcome in 25 eyes with this technique has shown a dramatic clearing, and this is the algorithm which we propose for the acute hydrops management based upon the location and the size of the lesion. Thank you very much for your patient hearing.
Thank you, Dr. Sunita. So I had 2 questions. One is there more of scarring because you put sutures, especially we are talking about patients where there is hydration of the visual axis. And second question was, do you remove the sutures at a particular stage or do you let them be?
Very good question. The sutures are taken and they are removed once the healing of the posterior membrane is taken. In the visual axis, the sutures are not taken within the stroma, they are taken on the corneal surface, meaning that the internal part of the sutures is in the stroma in the periphery. It is infinity suture and it is overlying the epithelium. It is not within the stroma. And the sutures are removed at, whenever the healing happens, and usually it is around 1 month. So we don't see much of scarring with this technique. But the remarkable resolution is pretty much rapid. So the scarring and vascularization which occurs because of long-standing eye drops is taken care of.
Thank you.
Post-op corneal edema could be an extension where you can use next day. There is severe corneal edema. You can always try for this and present it next time.